Good evening, friends. This is Dr. Kavi Sadana of Delhi, and my talk today is approach to reticulate pigmentary disorders, which is definitely a complicated topic, but I'll try to make it simple for you. Okay, right. So let's first begin with the first slide and tell you what is the meaning of reticulate. Reticulate has got two basic meanings. One is a net-like appearance, what you see on the left side, or what is more useful to understand is from biology, where you have a reticulate pattern on leaves. So this is the kind of pattern that we would be referring to. But of course, in my talk, I would have combined two terms, reticulate and dyschromatosis. So just to give you an idea, look at this particular slide. On the left side is a reticulate pattern. What you see on the right side is a pattern of pigmentation on the body, which looks like a net. Now, another term that I have combined in my lecture today is dyschromatosis. Now, this is, of course, classical reticulate pigmentation, where you see a net-like pattern on the extremities of this particular patient. Now, look at this particular patient. This patient has got lesions which are hypo and hyper. So when you have a mixture of freckle-like pigmentation that is both hyper and hypo, that is known as dyschromatosis. So I have clubbed the two in my talk, make it more all-encompassing. Of course, I'll be focusing only on genetic disorders. Now, for the approach to diagnosis, there are various approaches, but the one that I follow is give you an overview of the disorder, and then of course focus on a few important common conditions. The first thing that you should look at is inheritance. Now, in inheritance, most of the disorders are autosomal dominant, autosomal recessive, except a few X-linked recessive X-linked disorders, including dyskeratosis congenita and of course X-linked reticulate disorder. The second thing that you should look at is, of course, the age of onset. Usually it's in the infancy or early childhood. So, I mean, even if you look at congenital disorders, anything less than 2 years onset is congenital. So most of them are in that particular age group, except Dowling-Degoes that occurs at a later age group. The third thing, of course, is systemic involvement. Very crucial, very important, because some of these disorders have got involvement of other organs. For example, dyschromatosis, symmetric urticaria has got CNS involvement, even eye involvement, and dyskeratosis congenita has got bone marrow involvement and even cancer. So this is important to know. Some of these disorders may have systemic manifestations. Then, of course, we have hair, nail, and teeth. Very interestingly, some of these disorders affect these three structures, which makes it very simple to diagnose them. Classic example, of course, is dermatopathia pigmentosa reticularis, and a host of other overlap conditions with ectodermal dysplasia. The next thing you should look at, of course, is involvement of palm and soles. Quite a few of them have got acral involvement, and some of them are localized just there. So again, the Ketomera variant of acropigmentation, and of course, dyschromatosis, symmetric urticaria. Then, of course, you have the last thing, that is unusual thing, like maybe patients who've got sweating associated defects, or who have bulle appearing. So that's, of course, classically EBS with motile pigmentation, which I know nowadays it's probably not diagnosed morphologically, but it's good to know a morphological term for it. Now, so what classification would I use? We published a paper, a review article in the IGDVL a few years back, and this is a classification that I find very useful. It's called the regional distribution of these disorders. So there are 4 regions: generalized, acral, flexural, and facial. And the generalized, again, we have 2 categories: reticulate and dyschromatosis. In the true disorders of which are reticulate, you have, of course, the SARS1 dyschromatosis. SARS1 is basically a gene defect, so not easy to diagnose clinically. These patients usually have lentigens on their face and dyschromatosis on the body. Of course, dermatopathia pigmentosa reticularis, which I'll show a few slides of that. Dyskeratosis congenita, X-linked reticulate pigment disorder, which is basically has amyloid deposition, and of course the Naegeli-Sanchez-Tijeras syndrome, which has got bulle. Now, those conditions that are generalized with dyschromatosis, that is hyper and hypo, we have 4 conditions. One is dyschromatosis universalis hereditaria, and of course the acral variant of that, EBS with motile pigmentation, and again dyskeratosis congenita. In the acral variant, which is very commonly seen probably, is acropigmentation of Kitamura. DOHI is actually another name for Descomatosis symmetrica heterea, and the Cantu syndrome. In the flexural, we have Dolomdigos and its variant, the Gary-Daggett disease, which is basically a catalytic variant. And in the facial, of course, we have Haber syndrome and again the NFJ syndrome. So I think this is the most useful way of looking at these disorders, and one tends to diagnose them very easily with this particular classification. So now I'm going to run you through some photographs and give you a glimpse of what you may be able to see in clinical practice. Classic case of Descomatosis universalis given by my colleague Dr. Ananda Khana, and see this pigmentation. There's freckle-like pigmentation all over the body, hyper and hypo. This is of course a condition which has got two gene defects, SARS1 and ABCB6 gene, which explains the melanosome transfer defect, which also explains why they have hyper and hypo. Usually they are benign, of no great consequence, but some of them actually have involvement with the CNS and eye. Reasonably common, described in Japanese, but we see it even in our country. Then of course we have this condition. You see the pigmentation is localized to the flexural areas, and you will notice a few epidermoid cysts, and you'll have these very classical comedone-like lesions on the neck. So this is of course a classic case of Dolomdigos. There are two genes described for this defect, autosomal dominant. The most interesting part, apart from the flexural localization, is the classical comedone-like lesions. And there are also perioral period scars. They describe a classical pigmentation in biopsy called anthratype pigmentation. So fairly simple condition, easy to diagnose, and doesn't have too many complications. This is of course not my case. It's a very interesting and a very classical photograph of a pigmentary disorder. Just imagine this patient has got a reticular disorder in the body, and look at the patient's face. You have upswept hair and a flared eyebrow, and with of course pigmentation on the body, and that's X-linked reticulate pigment disorder. It's an unusual case report where they found a JAK inhibition defect. Very interesting. So this particular disorder, is important to diagnose, and it's got a very classical morphology. In females, you just see lesions on the lines of Blaschko. Biopsy would show amyloid, and this is a condition that has got complications, and that is one of the reasons why you should diagnose it. Opacification, GI inflammation, and a host of other things. So important to diagnose this early, especially in males where it's very obviously seen. Another condition, now here you have pigmentation of the palms and the body. You have non-cicatricial alopecia. If you see the slide on top, you have a loss of dermatoglyphics on one of the thumbs, and of course you have nail defects. This particular conglomeration is seen classically in dermatopathia pigmentosa, and also in NFJ syndrome. Now they usually overlap, but the classical dermatopathia is autosomal dominant keratin 514 defect, and it's considered by a lot of people as just an ectodermal dysplasia. Classical features are seen in most of these patients, this combination of hair, nail, and dermatoglyphic defects, and some of them have got PPK, and they usually overlap with NFJ syndrome, which probably is maybe just a variant. Important to know, especially because of the hypohidrosis and the dentitional defects, otherwise not many complications of this condition. Another disorder where you have again pigmentation, oral involvement. You can see the leukoplakic pigment plaques. You have tracheonychia, geographical tongue. Yeah, that's the case of combination of oral leukoplakia, geographical tongue, dysplastic nail. That's discretosis congenita for you. This is something which you must diagnose well in time, because these patients get into complications really badly. Most of them have marrow failure by the second or third decade, and there's a high risk of SCC, cancers, hematopoietic malignancies, and lacrimal duct atresia. So these patients actually may be diagnosed by a dentist or an ophthalmologist and then referred to you, and it's important to know this particular disorder for its complications. Another case, so here is a patient who's got reticulate pigmentation, which you cannot make out, but what's pronounced is hyperkeratotic papules on non-facial areas. This, of course, the published case where the patient got astatine with very good results. This is a variant, considered to be a variant of Jalan-Digos and called Gali-Gali disease. Of course, this is a very simple condition seen very often in most tertiary referral centers. Acral pigmentation, reticulate and pits on the palms. That's Kitamala for you. All right, nothing great in that. Now come to, of course, management. Now, management of these disorders is actually very tricky because, the first step, of course, is diagnosis. Most of us do not have a gene defect analysis laboratory. But if you suspect these disorders, you should do a systemic screen properly. A cancer screen is useful for certain disorders, like, for example, discrete splenectomy. The treatment of these disorders is very difficult, actually. People have used extensions of melasma therapy, topical agents like hydroquinone, retinoids, azelaic acid, with certain variable results. People have tried lasers, the Q-twist variant, but I guess the most important thing ultimately is counseling. So I'll come to the one thing which is very hot in conferences. Now, there's this famous law of the instrument, that is that if you have a hammer, everything that is around you looks like a nail. This is the cognitive bias in which basically you try to use whatever technique you have to treat a disorder. Classically, lasers. So lasers, if you go to conferences, you have some of the best results. They say the joke is seen in conferences. So can lasers be used in these disorders? So to understand that, this is a book that we have written, and it's a second edition. And I'll give you 3 principles of laser therapy, which you will not find in many other books, which I have learned by experience over the years. Number 1, static and dynamic disorders. Like, static disorders are easy to treat. For example, lead disease. For example, melasma, on the other hand, is dynamic. A patient has episodic melasma, it gets worse with certain factors. So never expect great results with melasma, but you get great results with lead disease. Similarly, you have epidermal and dermal disorders. So the epidermal disorders are easy to treat, and dermal disorders are difficult to treat. So lead disease are easy to treat because the epidermal, and the dermal disorders like nevus of Otta are very difficult to treat. Ochronosis, things like that. In fact, the joke is that the best Otta results are seen only in conference talks. And the last thing, the most important thing, is skin of color. Our skin types, if you overdo your Nd:YAG lasers, you cause thermal damage and you lead to PIL. So you have to use these 3 principles and apply them to these disorders, and suddenly you find that the only condition that you can treat sufficiently well is Kitamura. Kitamura is something you can try, and the rest, it's tiresome. So I'll give you an example of one particular case. This is a patient who came to us, child with discomatosis, unisalis heritaria, and of course, my PG said, "Sam, let's try lasers." I said, "Go ahead." So we use 500 nanometers because we were targeting the pigmented part, not the hypo. The settings depend on the endpoints, what you see, what is slide, the whitening. And now just see how laborious it is. You have a probe size. Even if you increase your probe size, you can't go to 510 mm because you'll be unnecessarily hitting the normal skin. So you have to go to 2 mm. There are settings there with the aiming beam, and look at the laborious extent. You got to keep on targeting each of these pigmented lesions. It's highly laborious, and so I told my resident, go ahead, do it, and I think by the 3rd setting he lost interest. So the thumb rule is, don't unnecessarily force a treatment. So when patient comes to me and asks me in the end of the whole story, diagnose a disorder and feel very happy about it, and the patient comes back and says, now what? So there's a very famous adage which you should use for certain disorders like this, and that is this: it is not necessary that every problem has a solution. You have to learn to live with some problems, and rather than forcing a solution like lasers and doing a blunder. So philosophically speaking, people have solutions for your problems, not their own. But more importantly, for this spectrum of disorders, it makes sense to diagnose, advise, counsel, look for complications, and live with it. So that was my last slide. Thank you very much for patient hearing, and thank you for the Academy and the SIG group for calling me over for this talk, and thanks to Dr. Rahul Mahajan for the great invite. Thank you so much, and a good day.